to have you join us. Okay, and we will please take care of admitting all those who join in between.
Yes, sir.
I'm going to start my presentation like we did yesterday, sharp at 6 o'clock. And I am going to talk about ABO incompatible kidney transplant. I think in the last few years, we discussed yesterday that in the field of transplant, immunosuppression has remained the same. The advances have been in the field of transplant immunology and better understanding of the immunological risk factors and the tests available to judge the immunological risk of the patient. The other important advances I see in the last decade has been in the field of ABO incompatible kidney transplant. This is something which was considered an absolute contraindication when I was training. And then for many years, we never thought of considering ABO incompatible kidney transplant, but it has now become a routine, and about 20 to 25% of our kidney transplants are ABO incompatible. What I am going to do is tell you how our ABO incompatible kidney transplant program has evolved. So there was a 37-year-old male who presented to us in 2010 from Delhi for kidney transplant. And that is because his blood group was B, his donor's blood group was A, and as I said, ABO incompatibility was not acceptable for kidney transplant, and he presented to us. So what were the options for him in 2010? He could have continued with dialysis, which we know is a poorer option. He could have registered himself for deceased donor transplant, and that program was not so developed at that time, and it's even now not a very well developed program in our country. He could have opted for a living unrelated donor transplant, which is not legal in our country. He could have planned a paired exchange, what we call swap transplant in our country, or he could have gone for an ABO incompatible transplant. In that setting, we identified another pair for him where recipient's blood group was A and donor was B, and we performed a successful swap transplant. So this is what happened. One of the donors had blood group A, recipient has blood group A, and the donor was blood group B. They were incompatible. This pair was incompatible, and the donor of first pair donated to recipient of the second pair, and donor of the second pair donated to recipient of the first pair. So this is what we did for that patient. Thereafter, we did a series of swap transplants, and we were leaders in the field of performing swap transplants for ABO incompatible cases. But there are problems about doing swap transplant in our country. One is the legal problem, and then there's a problem when the recipient has an O blood group or the donor is AB blood group. What is the legal problem? Swap transplant is considered unrelated, even if the two pairs are related, and it requires many legal formalities like for unrelated transplant. As per transplantation of human organ rules, it is mandatory that if donor, recipient, and place of transplantation are from different states, NOC from respective state governments should be obtained. This is for unrelated transplants. So we were working up a swap transplant where one recipient donor group was from Gujarat and another pair, daughter getting a kidney from mother, they were from two different states. The daughter was in Rajasthan and mother in Haryana. they had to get NOC from 3 states, Gujarat, Rajasthan, and Haryana, to get transplant done in Mumbai. The whole exercise took 7 months. So this is something that is realized. This also was highlighted in the newspaper. Unfortunately, even after so many years, nothing has changed, and this rule persists, and therefore it's a big legal hassle for patients coming from different states. The problem with O blood group is, here you have pair 1, this is not compatible. In pair 2, you have donor who is O positive, recipient is A, this is compatible. So why would this pair want to do a swap transplant? Despite this, in that time, we worked in a few cases convincing this pair to help the other pair, and we performed a swap transplant even when some of the pairs had an O group donor and could have donated to their own recipient. And the same problem is about a donor who is AB blood. So what is the practical solution? The practical solution in cases like this is an ABO incompatible transplant. And our real thought process and efforts to get into ABO incompatible transplant started with Professor Tanabe from Tokyo Women University in Japan visiting us and giving us a presentation about his experience with ABO incompatible kidney transplant. So after Professor Tanabe's visit, we performed our first ABO incompatible kidney transplant on a 40 years old male whose blood group was B, and the donor was his wife with blood group A. This was our desensitization protocol. At that time, we followed practically the protocol that was being followed in Tokyo Women's University, rituximab on day -14, then starting of maintenance immunosuppression by day -7, then do a series of plasmapheresis or use glycosol adsorption to reduce the antibody titers. On the day of transplant, give second dose of rituximab, thymoglobulin or basiliximab as induction, solumedrol 500 milligram rapidly tapered to 10 milligram by 1 week to 10 days. Adsorption cartridge was used if the titer was more than 1024, otherwise we would manage with plasmapheresis itself because this is quite expensive. It would cost about 3.5 lakhs today, 3.5 to 4 lakhs today. And transplant was performed if titers were less than 1:16, and we were monitoring titers daily after transplant. And soon we did many transplants, and we learned how this anti-blood group antibody titers behave in response to desensitization and in response to kidney transplantation. And we found that in about 20 to 25% of the cases, the titers are low to begin with. In a majority of the cases, on an average, the titers are about 1:64. It is not difficult to desensitize. And after transplant, in most people, the titers drop to less than 1:8. So it was not at all difficult to manage the patients. And these patients behaved almost like ABO compatible transplant. So this is how, on an average, the titers would behave. The average baseline titers would be 1:64. With 2 or 3 plasmapheresis, we would bring down the titer to 1:16. And then the titers would remain low. And thereafter, we know that nothing happens even if the titers rise. I'll discuss about this later on. After doing a few transplants, we realized that there were higher infectious complications. So we changed our desensitization protocol in the sense that instead of giving rituximab 2 times, we gave only once, and we changed our induction from thymoglobulin to basiliximab because With thymoglobulin, it amounted to suppressing the T cell series, rituximab suppressing the B cell series, and the infectious complications for more. So we changed our desensitization protocol like this. Now, how do we monitor anti-blood group antibody titers after transplant? So there are four situations that we see. In about 50% of the cases, the graft remains stable and the anti-blood group antibody titers remain low, nothing needs to be done. The patients behave like regular ABO-compatible transplants. In some cases, the antibody titers remain stable, they remain low, and there is an allograft dysfunction, wherein you have to work up like any allograft dysfunction, even in an ABO-compatible transplant. Then you may have a rising anti-blood group antibody titers and allograft dysfunction, in which case one would think that it is because of this and one would try and bring down the titers. But there can also be a scenario where you have rising anti-blood group antibody titers, the graft remains stable, and here is where one is worried whether one should reduce the antibody titers by plasmapheresis or by use of adsorption filter. So we have come across all the situations. We had a 53-year-old female, blood group B. Donor was a 60 years old husband with blood group A, and kidney transplant was performed when the titers were brought down to 1:8. And she did well in the early period after transplant for the first few days, and the creatinine came down to 1.4. On day 7, there was a rise in creatinine. Her titers were low. A kidney biopsy was performed, which showed antibody-mediated rejection. Her HLA cross-match was done, which was positive. So here it was an HLA antibody-mediated rejection coming up after transplant. Now take another scenario where you have rising anti-blood group antibody titers and graft dysfunction. So we had a 51-year-old male with end-stage renal disease due to chronic glomerulonephritis. He underwent a preemptive transplant with his wife as the donor after desensitization. Induction was basiliximab followed by standard triple immunosuppression. There was a prompt graft function and his creatinine rapidly dropped. You can see 0, 1, 2, 3, 4 to 0.62. On day 6, he developed gross hematuria. Creatinine increased to 1.09 from 0.6, and his anti-B IgG titer, which was 1:4 pre-op, had risen to 1:128. We took this as anti-blood group antibody mediated rejection. We could not do biopsy because of low platelets. We treated empirically with solumetrol, plasmapheresis, IVIG, rituximab, and bortezomib, and he improved and stabilized at a creatinine of 0.7, and he continues to do well even today. So this is how his creatinine behaved. It had come down to the lowest value, and then it started rising with hematuria, and this coincided with the rise in his titers, and we empirically treated him as anti-blood group antibody mediated rejection. We now come to the third scenario, where you have a rising anti-blood group antibody titer and a stable graft function. So we had a 43 years old female with end-stage kidney disease due to tubulointerstitial disease. Her blood group was O. Donor was a spouse with blood group A. The baseline titers were 1:5:2. We look at mainly IgG antibody titers, which was 1:5:2. So that was brought down on day 0 to 1:16. And after the transplant, there was a rapid drop in her creatinine. By day 2, her creatinine dropped to 1.03. Day 3 it was 0.68, but you can see that the IgG antibody titers kept on rising. It was 1 is to 64, and then on day 4 it was 1 is to 256, although the creatinine was stable. I was attending a meeting at that time, and my colleague called me that we are worried, we will go ahead with plasmapheresis. So they went ahead and did plasmapheresis. In the meantime, I wrote to Professor Tanabe and I told him that we performed a transplant where the baseline titer was 1 is to 1024. Transplant was performed when the titer was brought down to 1 is to 16. She's doing well, but her titers have jumped to this, and what should we do? And Professor Tanabe promptly replied, you do not need to give any plasma exchange in case the renal function is stable. So after giving that plasmapheresis, we just closely monitored her kidney function, and her IgG antibody titers went on increasing, and it went to 512 by day 8, but her graft continued to remain stable. No further plasmapheresis was done, and she continued to remain well. The next part in our evaluation was individualizing the whole protocol according to the patient. So there was a study which showed that you can have a good outcome of ABO-incompatible transplant without splenectomy or rituximab. So one of the problems with ABO-incompatible transplant is that with use of rituximab and plasmapheresis, your overall immunosuppression increases. And because of this overall increase in immunosuppression, there is an increased risk of infection. And we did see more infectious complications. So in the next patient, when I had an elderly, frail lady with end-stage renal disease, ABO-incompatible transplant, we decided not to use rituximab. So a 61-year-old female with end-stage kidney disease, with tubulointerstitial disease, her blood group was B. Her donor had blood group of A. The baseline titers were 1 is to 64. No rituximab was used. She was desensitized with plasmapheresis. We did give IVIG, 100 milligrams per kilogram after each plasmapheresis. When the titers were 1 is to 8, after 3 plasmapheresis, we took her up for transplant. This was her protocol. On day -7, we started her on maintenance immunosuppression. We gave her plasmapheresis plus IVIG. On day 0, we gave solumedrol and basiliximab. Basiliximab was repeated on day 4. And this is how her titers behave. So we brought down her titers to low levels on the time of transplant, and this is how her creatinine behaved. Soon after transplant, her creatinine rapidly dropped. And you can see that by day 3, her titers started rising to 1 is to 32, and then 1 is to 64. And by day 6, the titer was 1 is to 128. However, based on our past experience with a stable graft function, we did not do anything. She continued to do well, and she continues to do well even today. An interesting feature after ABO-incompatible transplant is that after a certain period, no antibody-mediated, blood group antibody-related, antibody-mediated rejection occurs despite rise in antibody titers. This phenomena is called accommodation. How soon after transplant accommodation develops is not known. Accommodated grafts do show C4D deposition. So if you were to do kidney biopsy in a patient who has had an ABO-incompatible kidney transplant, even if the graft is functioning well, you will find C4D deposition. This suggests that antibody binding and complement fixation has occurred. But lack of injury In centers where they do protocol biopsies, they have found C4D deposition, but there is no injury. The graft function is good. Lack of injury implicates some form of regulatory pathway as the basis for graft survival in accommodation. What these regulatory pathways are is an area of ongoing research. We did a simple study in one of our ABO incompatible transplant patients who had rising antibody titers and had stable graft function. To detect if the patient is specifically unresponsive to donor RBC antigens, an RBC crossmatch test was done using recipient serum and donor's RBCs, and we also used random RBC of the same blood group as that of the donor. The donor RBC and random RBCs suspended in hypotonic buffered saline solution were mixed with recipient's serum in different dilutions. And you can see over here, the first tube is the recipient serum to which her donor's blood has been added, RBCs have been added. There is 1:1 dilution, and you can see a band developing here which shows agglutination. That means the crossmatch is positive. And these are random red blood cells which also showed the same type of agglutination. With 1:2 dilution, there was the same agglutination. And as the dilution increased, you can see that agglutination did not occur and the RBCs sink down at the bottom of the tube. The point to be seen is that there was no difference whether you add RBCs of her donor or you add RBCs of a random person with the same blood group as her donor. So there was no specific unresponsiveness to the RBC antigens of the donor. And therefore, the mechanism of accommodation is still a mystery, and a lot of work needs to be done to understand that. Some people have postulated that these are not RBC antigens, but they are RBC associated antigens, and that may be the reason why there may not be a rejection despite a rise in antibody titers. What is the outcome of ABO incompatible kidney transplant? So there is obviously a learning curve, and each center will have its own learning curve. I looked up at meta-analysis rather than single center studies. If you look at Professor Tanabe's experience, then they found the results to be as good as ABO compatible transplants. But in a meta-analysis, ABO incompatible kidney transplant recipients were found to have good outcomes, albeit inferior to center-matched ABO compatible control patients. So if you see this visual image, they compared 4,943 ABO compatible transplants and 1,346 ABO incompatible transplants. The graft survival was not too bad, although slightly inferior, but the infections were higher, rejections were higher, and non-viral infections were higher. So the outcome is slightly inferior to what one can achieve with ABO compatible transplant. The same thing was seen in another meta-analysis where, despite progress in desensitization protocol and optimization of ABO incompatible renal transplant procedures, the mortality and loss of kidney graft was found compared with ABO compatible transplant in the first 3 years was found to be less. In the long term, the results are comparable, but in the first 3 years, the outcome was slightly inferior to that of ABO compatible kidney transplant. However, this is far superior to what could be the outcome of these patients who would be on dialysis. So ABO incompatible transplant is still an excellent option. And as I said, there is always going to be a learning curve. So after our initial transplants, in our later transplants, we see no difference between our ABO incompatible and compatible transplants. So at our center, same as what meta-analysis has shown, the outcome is slightly inferior. The patient survival is slightly inferior with a greater loss in the early period, and then the two curves seem to be becoming similar, and the same thing about the graphs. But in the recent years, in the last 25 transplants, our outcome has been the same as that with ABO compatible transplants. Some interesting cases that we have performed, which were ABO incompatible. We performed an ABO incompatible living related transplant in an HIV positive patient. And what we did in this HIV positive, this was in the early period of our ABO incompatible transplant. As I said, we reduced from 2 rituximab injections to 1, and we did not use any induction for her, and she continues to do well. We have also done steroid-free transplant in small children, in young children, growing children. We do without steroids. 9-year-old child, primary disease, obstructive nephropathy, posterior urethral valves, fulguration done at 4 months, right ureterostomy at 2 years, approach end-stage kidney disease in 2017. The baseline titers were more than 1024. He was desensitized with Ritux and plasmapheresis. His pre-transplant titers were brought down to 1:4. Transplant done on 6th May 2017 with right native nephrectomy and a ureterocystoplasty for bladder augmentation. Solumedrol and thymoglobulin here was used because we wanted to do a steroid-free transplant over here. Steroids stopped on day 5, and he continues to do well even today. So in the recent years, this is the only scenario where we would use thymoglobulin as induction. Otherwise, by and large, it is basiliximab. So in summary, in our country, more than 95% of transplants are with living-related donors. About 1/3 of potential living-related donors are ABO incompatible, which means a decade back, we were denying them a transplant. That's a big number. While swab transplant is an option, this is difficult in our country due to legal hurdles, and it is difficult for O blood group recipient and an AB donor. ABO incompatible transplant is an excellent option compared to alternative, which is dialysis. So although the outcome is a little inferior to ABO compatible transplant, it still is a far superior option to continuing on dialysis. In almost 20 to 25% of the cases, anti-blood group antibody titers are low, and these patients may not need any desensitization. You may just treat them as ABO compatible transplant. So it is important that one does not refuse just because of ABO incompatibility. At least do the titers and see what the titers are. In most cases, the anti-blood group antibody titers remain low after kidney transplant. Even if the titers rise, if the allograft function is stable, nothing is required to be done. At some centers, they try to do plasmapheresis and reduce the antibody levels, but that's not required. How long are you going to do? Accommodation can set in early. With experience, results of ABO incompatible transplant can match those of ABO compatible transplant. I would like to thank my mentors who have built me up in doing transplants and taking calculated risks, and my team who has been always motivating and keeping me on the toes to keep doing something new all the time. And this is how we have built our ABO incompatible kidney transplant program. But there is an important message that I would want everyone to have, that if we were to educate all our patients, our family, society, to not take their organs to heaven, for they are needed here. If we were to guide them to sign an organ donor card, and if all were to sign an organ donor card and pledge their organs after that, then we would not require ABO incompatible transplant, we would not need to do any living related donor transplant, and we'll have sufficient number of cadaver donors to be able to do all kidney transplants for those who need them, and not only kidney, it would be liver, heart, lung. So we really need to work on making this a bigger program in our country. Thank you for joining us, and I would be happy to take the questions. The right native nephrectomy was done because it was an infected kidney. Vikas.
Bharat, I have one question.
Yes.
There are some publications from some centers where they use IVIG, rituximab, IVIG, and no plasmapheresis. What is your opinion on that?
I don't know of centers not bringing down the antibody titers. I think that would not be safe. I have not heard of that, Uma.
No, I recently read a couple of articles which said without plasmapheresis, ABO incompatible transplantation, and what they had used is prepared them with IVIG.
I would like to see what titers they could achieve, because sometimes what happens is when you use IVIG, the IVIG that we infuse itself leads to an increase in titers and confuses us.
Right.
So there have been some reports of rise in antibody titers after infusion of IVIG. So I would be a little surprised. I would like, if you could pass on that paper, I would like to study that paper.
Yeah,
I think, sir, in such cases, no, the beginning titers are very low.
So if the titers are low, then we don't need to do, as I said, we need no desensitization. We don't.
Yeah, if you carefully read those papers from Australia, where they said that you don't need plasmapheresis and even rituximab. So if you see their mean titers, they started a mean titer of 16, 1:16. So anyways, we at our center also, we have not given anything, no rituximab and no plasma exchange, and we have gone ahead and done an ABO incompatible transplant recently.
So recently we had a young lady in whom we just used rituximab because the baseline titer was 1:32, and we did not do any plasmapheresis and took her up for transplant. We didn't use even IVI.
So critically seeing or critically analyzing these patients are very important. Whatever the headline may be different, but if you go through them, majority of these patients have titers of less than 1:32 or so. So these patients may not need anything actually.
There's one question from Vikas, that was the child in whom we performed the transplant, steroid free, was he very polyuric pre-transplant? If HEPAL is there, then HEPAL is a pediatric nephrologist. She would be able to tell us. Do you remember, Prashant?
Yes, sir. So no, he had a good urine output. He was not polyuric. Okay, he had a decent urine output prior to the transplant, and he was taken up as a preemptive transplantation. So whenever I think his creatinine was about 3.5, and his GFR was quite low. That was the time when we took him. His output was very well prepared.
So because as I said, about 1/3 of our transplants are preemptive. We prepare them as we see them progressing. We prepare them directly for transplant. Any comment you want to make, Vikas?
The reason I asked was, these obstructive uropathy children, they maintain a high urine output even when their native kidneys have failed. Then our post-transplant management has been tricky because there's so much urine output to replace, and the children cannot take in 3 to 4 liters a day, which sometimes we are forced to do. So some of the children's hospitals in the US do this right native nephrectomy at the time of either living or deceased donor transplant to reduce some of the native kidney urine output. So that was the reason I asked that question.
No, that was not. This was an infected kidney. We didn't want to leave a source of infection. You know, he had a right ureterostomy for quite some time. Is that right, Prashant?
Yes, sir, yes, sir. He was having infection, and that was the reason why we did the nephrectomy.
There is another question. What titers you target before transplant in ABOI? So earlier we were targeting 1:16, but now we accept 1:32.
Is there any substance A and substance B which is available? Like what we use plasma in the replacement, that also have a dissolved antigen which combines with an antibody and reduces the level. The previous Alexander and this the paper there has been mentioned that they injected 5 ml of substance A and substance B after the plasmapheresis. I searched, I could not get any substance A in the market. Whether you have any idea, sir?
What is that substance A? I have not heard.
I think
it's like an antigen of substance, and the blood group A antigen, blood group B antigen.
Okay.
So
no, I think
it's reason, when we do plasmapheresis, we replace 500 ml with donor blood group plasma.
Yes, sir.
With the idea that it contains the antigen which will bind with the antibodies.
Right, sir. Sir, if no a plasma has to be given, whether this can be an alternative option, that's the reason I asked. Okay. Because the dissolved antigen, it will act in a similar manner.
Okay, okay. There is a question, do you routinely check titers post-transplant? So yes, in the early period, we were checking very regularly. In those cases where the titers were very high, sometimes we would do the titers twice a day. And as I said that in most cases, the titers remain low. So after learning that, we don't do it so frequently, but we still do it on alternate days or once in 3 days. How about you, Umapati?
So we check only in the 3rd day or 4th day. Now earlier we used to check every on the 2nd day and 4th day and 7th day and 10th day. Now we have stopped. Unless there is a graft dysfunction, we don't check it. Only once for documentation, we check on after around 3 days, 72 hours, we check it. Most of the times we don't require anything, and the titers are maintained lower, less than 1:16 or equal to that.
Okay. We will be happy to have some comments from others' experiences.
We also had initially started after the initial protocol was ATG, because the first patient what we did was wife. We didn't have any problems, but in the second also it was the wife, because there was no alternative donor. We were forced to use, most of them are spouses. But we had a lot of infections, including fungal infection, because we are blocking B cell and also the T cell. Both are blocked. We had more of a fungal infections. So that is the reason we have stopped using an ATG unless is there any severe rejections or T cell which is not responding later. We are using either a bacilleximab or no induction. Up to around 30% of our patients with ABO incompatible, because the DSA is negative and they have received rituximab and underwent a plasmapheresis. 30% of our patients are no induction, and otherwise we'll use bacilleximab.
So in 30% of your ABO incompatible transplant, you use no induction.
No induction, because we have already given as a desensitization rituximab we have given, so we don't use bacilleximab also.
Okay, okay. But what about then the risk of T cell mediated rejection?
So we are already starting the TACRO, even already 12 to 14 days prior. I think the sufficient level is maintained. So we didn't have any significant increased T cell without any induction.
Right, right. There's a question whether we do subtyping of blood group A, whether it is A1 or A2. Yes, we do it. But whatever it is, we would try and bring down the titers. It is A1 blood group which is supposed to be more immunogenic, and we do for all A blood group patients we do subtyping. How about you?
So we do A1 and A2, and if the donor is A2, then it is like an O. It is boom to it. It will be very good, and we hopefully we don't get any significant rejection. It will act as an O donor.
Right, right.
Bharat?
Yes.
So I got a couple of questions.
Yeah.
First of all, we've in our center we used to do, means I moved out from the previous center, but what we had done was we initially looked at the titers coming down to 1:8 and then transplant them.
Right.
And we used to use the rituximab as well at the same time. So
right.
2 doses of rituximab as well. No immunoglobulins, no thymoglobulins or ATG, but they just usual standard immunosuppression. But what we were worried about is when you use rituximab, you are trying to reduce the risk of having humoral ABMR, basically. Humoral rejection. And that's the reason to use rituximab.
Right.
The problem with this kind of transplant is you would never know if you have a humoral rejection. It will always be confusing whether that rejection is from the HLA, from the ABO incompatible one, or whether it's the actual
HLA antibody.
The usual transplant we say.
Yeah.
So the way we have worked out is we do DSAs. We don't look after the titers anyway. After the transplant, we just do the transplant, forget about the titers. ABO titers are not measured afterwards. But what we look at is the DSA, donor-specific antigens, to determine if they have got humoral rejection. Do you do that?
So as I said that if the titers are low and if it appears an immunological mediated rejection, then yes, we do a cross match. We look for donor specific antibodies. We do that. So we repeat a cross match, and it happens that a cross match which was negative before transplant, now you get it positive, and it correlates with your antibody mediated rejection.
You mean the ABO titers rise, that gives you indication that there is an ABMR?
No. If the ABO titers rise and if the graft is stable, we do nothing. Okay. If the ABO titers rise and if there is an allograft dysfunction for which we find no other cause, then we would presume it to be ABO blood group antibody mediated rejection. On the other hand, if there is an allograft dysfunction which appears to be immunologically mediated, but ABO titers have not risen, then we would presume it to be HLA antibody mediated rejection. In essence, the treatment would remain the same, whether it is anti-blood group antibody mediated or HLA antibody mediated. Our effort would be to do plasmapheresis and give IVIG.
Yeah, that's right. I think that's what we would do. What we have done is our protocol is that if we find a rise in titers, rise in creatinine, obviously not the titers, we do a DSA, we do a biopsy, pulse them with steroids, and then decide, depending on the biopsy, we decide if it is obviously if it's C4D positive, we go for the ABMR way, or if it is not, then we go by the usual rejection pathway, just steroids and increasing the TAC or MMF.
Right.
So that's very important to know that because what we understand is that the ABO incompatible transplants, wherever you got the HLA type 1 antibody mediated immunological response, it really does not affect the graft. So the ABO incompatible thing really doesn't affect the graft at all. It's only to do with whatever HLA type 2 DSAs and all that will cause the graft rejection. So we have to just concentrate on that half of the story.
So Jitendra, are you saying that if after transplant, if anti-blood group antibody titers rise, and if there is an allograft dysfunction, which is appearing to be immunological, then it is HLA antibody mediated and not Blood group antibody mediated?
That's right. Because if you have a HLA type 1, which is the ABO incompatible antigens or antibodies, that will actually cause a picture which will be thrombosis or DIC-like picture, where you have a very hyperacute rejection, which your patient must have had in the one which you did the transplant. You said he had hematuria.
What makes you think that it is not blood group antibody mediated rejection?
Because blood group antibodies are actually the antigens are present on the RBCs only.
No, they are present on the endothelium.
Yeah, no, they are present on the endothelium.
See,
so they are present on the endothelium, but they are not reactive.
No, there's the antibody which. Sorry for interrupting, sir.
Jitendra, in the past, the ABO incompatible transplants that were done, like if you see some of the earlier papers, 8 out of 10 transplants had a hyperacute rejection.
Yeah, but then we also know that those hyperacute rejections were because they had preformed antibodies.
No, but then if that was the case, how would the transplant have improved by lowering the antibody titers? You think they were reducing the HLA antibodies?
Yeah, so if the ABO incompatible transplants in these situations, what we understand from what I have learned here is that the agglutinins which are there are actually only directed towards the RBCs, and they only go around that. And if you clear those, then there is very less risk that they will cause any problem or rejection.
So going by your point, if you have ABO incompatible transplant and no donor specific antibodies, you don't need to do any desensitization.
Yes, that's why I think what you're seeing nowadays is that they can do away with even plasma exchange, plasmapheresis. So there is a different thought process, because the antigen, what we are trying to see is whether the agglutinins which are there, which are the RBC agglutinins, are actually only responsive to the antigens on the RBCs. And the endothelial antigens are actually very few. So the expression of the antigens are different.
So still, if there is a low titer, you can get away without that. We are also doing an DSA prior to the transplant, and the people have showed that the double outside, because HLA incompatibility, ABO incompatibility. If the person don't have an DSA and an ABO incompatible, they do better. If they have an associated DSA, they do worse. And if it is again as a control as ABO compatible transplant without DSA. But if the titer is more than 1:64 or 128, you definitely require. Even with Japan, they had gone up to 1:128 titer without plasmapheresis. But beyond that, when the titer goes higher, then they have rejections. Even endothelial, they have receptors, and they will have.
I agree. What Umapati you're telling me is that what you understand is that when you got a higher titer, it means that the person has got very high immunogenicity. So they are very reactive, and they have already been exposed to some kind of antigen in the past. So if you have someone who has got a hereditary disease, or you've got obstructive uropathy causing end-stage renal disease, in those patients you can get away without having heavy immunosuppression. But if you have someone who's got glomerulonephritis, SLE, or say IgA nephropathy, all these patients are very immunogenic. They are very immune active. So in these patients, you will have to suppress them heavily. But I would suggest that instead of giving them ATG, which is a very, very strong immunosuppression, don't use ATG, just use rituximab. And again, steroids as well. We have found that there is a very, very high risk of getting secondary infection if you use highest dose steroids. We taper our steroids to 20 milligrams, means we start with 500 first dose, and then it is 20 milligrams every day. So we don't even use higher dose. And by like 6 weeks, our dose is, or 4 weeks, our dose is 5 milligrams. So very low dose steroids, and don't use too much of ATG. You can use rituximab.
So we are not using the ATG at all nowadays. Initial 5 transplant, 10 transplant we used. After that, no ATG. So we are not using an ATG as an induction in ABO incontinence because we are using rituximab. That also we have reduced to 200 milligrams because we know it is also more immunosuppression because the plasmapheresis is also an immunosuppression.
Yes, yes.
Well,
if you use that, that is enough.
Jitendra, we will have to move on to the next lecture, but we will be in touch. And I'm quite interested by what you have discussed today, and I would like to learn more about this. Having said this, thank you for this interesting discussion that we had today. I now request, is it going to be Dr. Vivek or Dr. Umapati to?
Vivek, if he's there.
Is Dr. Vivek Kute there? Dr. Vivek?
Sir, I'm not able to see him. This is Vipul here.
Dr. Vivek is not there?
No, sir.
Well, then, Umapati, will you be able to
Sure.
take your...
Sure, sir.
Yeah.
Sir, just give me 1 more minute. I will make him admin. Sir, now you can present.
Okay. Good evening, everyone. Thanks, Paracha sir and Global Hospital team for giving this opportunity. So the topic is benefits of early conversion of mTOR inhibitors in early post-transplant. So I'm going to have introduction, major causes of graft loss, the mTOR inhibitors and its benefits, the late conversion, what it's shown. So we all know that we have understood, again, we have much more to understand, but with the time, the acute rejections have significantly reduced with better understanding of the immunology and the better drugs available from 60 to 5 to 20%. And the first year survival, which was only around 40 to 50% in 1965, which improved to around 95% now. So it is the short-term outcome has improved. It's because of the drugs which have serially available. Earlier, people were done with azathioprine and steroids, and now cyclosporin has made wonders by reducing the rejection episodes and increasing survival to 80%. And then the mycophenolate mofetil came, then the rituximab and the thymoglobin induction and the other belatacept and everolimus. Everything came in around 2012 to 13, which increased the survival in those patients also. So this which already shows that from 1989, the half-life for the capillary survival, which was 6.8, it increased to 8.4. Again, it is still less. We need to have much more. Why this only from increase from 6.8 to 8.4 is we have able to reduce the attrition risk in the first year. So if you see the deceased donor transplant, the attrition risk in first year in 1989 was 20%, which is reduced to 8% in 2009 or 10. But if you see the 1 to 3 years or 3 to 5 years, it remained the static almost because because of the immunology and the complications. So the major causes of graft loss are death with functioning graft, and even cardiovascular diseases are more, but again in our country it's a death with functioning or infection is the most common cause, and with the patient loss, and CAN is another important cause. Otherwise nowadays what we are seeing is a chronic, this CAN earlier and now it is more of a chronic immunological mediated also it comes to it. So earlier it was CAN, which people used to say it's only a majority is cyclosporin or a calcineurin toxicity. Now we know that it could be an immunological disease or the immunological factors. In the non-immunological factors, it's an older kidney. Nowadays we are pushed to take even 65 years old or 70 years old kidney because of the non-availability of the other donors, or even in the deceased donor, brainstem injury, preservation injury, and they have a delayed graft function, or an hypertension which causes long-term damage, hyperlipidemia, and the chronic toxicity of cyclosporin or tacrolimus on the graft, which also increases. These are all non-immunological causes. In the non-adherence or the non-compliance of the patient is an important factor what we are using the graft on a long term. And even after 5 to 10 years, the non-compliance is seen, and which cumulative, and the suboptimal immunosuppression because of the non-compliance, which leads to decrease in the level for 5 consecutive days or 5 consecutive doses. So then you will have a subacute or a chronic allogeneic injury, and it leads to increased HLA incompatibility or in HLA antibodies and leads to failure. So the unmet need is basically what we have is the long-term renal survival has marginally improved. It has improved definitely, and the IFTA and the death with functioning graft are the major causes. The current immunosuppressions are not adequate completely to take over the long-term graft dysfunctions, and the CNR toxicity is one of them, and CNR sparing or a minimization strategies are required. The mTORs is one of them, and it's basically the sirolimus or everolimus. It binds to the FKBP12 and blocks the mTOR pathway, which is most important. It inhibits the mTOR C1, and then it will all lead to the cellular biogenesis, and it stops the proliferation of B cells at G1. So it's basically the DNA replication or the cyclical arrest which happens in G1, and it leads to the immunosuppression. And the multiple reasons which how it acts is immunomodulation. It prevents the T cell proliferation also, and it increases the regulatory T cells, which are important in reducing the viral infection, which I'll come to that. It has an anti-oncogenic property by stopping the mTOR and also inhibiting the angiogenesis and blocking the PPTEN. The viral infections are less because it increased the mTOR. Before that, they have a PIC and AKT and mTOR C1, which are all required for the viral multiplications. And if you block that, the viral multiplication also will go down, and the cardioprotectionness also there. And we all know that people are using sirolimus coated stents in the coronaries also. So if you see the different stages, inhibition of core stimulation, where Bellatus majorly acts, and the depletion of T cells, and the depletion of B cells, and depletion of plasma cells, if you see, and even others, if you see the interaction of T1 cells, the mTOR, you can see the inhibition of proliferation, you can see the mTOR, and B cell differentiation and IgG production also is affected, and the inhibition of the IgG mediated endothelial signaling is also blocked. So the major difference is what earlier it came as a sirolimus, now the everolimus which is there. The viability of the everolimus is much higher, as there is a change by the hydrophilic group addition of hydroxyethyl group. So the half-life is much less. So if the level is higher, it takes 5 times to reduce it. So you have to have a BD dose for everolimus. No loading dose is required. Steady state, it takes 4 days as compared to this around 7 to 8 days. So target level are around 3 to 8 and 4 to 7. So I'll come with a case. It's a 40-year-old male who underwent a transplant in 2013, and he came to us with 2 weeks of history, and creatinine was 11 and the hemoglobin was 5.3, and he underwent a peritoneal dialysis and then initiated on hemodialysis. Wife was evaluated a donor because there were no other family members for donation, and underwent a transplant in 2013 because the wife donor and nil match, and he underwent an ATG induction, and the urine started immediately, and the serum creatinine reduced on the post-op day, and then achieved on the 5th post-op day to 1.32. You see, after that, creatinine serially increased, and he had the renal function slowly deteriorated to around 5, and then we stopped the tacrolimus. He underwent a biopsy, and the graft dysfunction which was there, which serially the creatinine came down to 1.37, started going up, and the biopsy did not show any TMA, or there was no rejection. The level, tacrolimus level was very, very high. So we stopped it, and then the renal function slowly came back to 1.6. And because it was a wife donor, no match, we thought we'll reintroduce it with a lower dose of TAC, but again, it started going up. And once it came down, we restarted, but again, it started going up. So the level at this time was also, it was only around 5 nanograms, but still it was going up. And he was treated with MP and then ATG. The repeat biopsy did not show anything. So because it was a wife donor and he was not tolerating things and there was no TMA, we started with everolimus and he did well. And now also he's doing well with around 1.3 creatinine even after 7 years. So where the everolimus plays as an important or the potency of the immunosuppression, if you see the calcinutrins are the most important, the efficacy wise, but we have a long-term problems because it causes the CAN and increase the cardiovascular disease and the cancer. The second potent possibly is everolimus or sirolimus as a potency wise. It all reduces the CAN, but has an equivocal, but it reduces the cancer. And then comes the prednisolone and also the MPA. So the potency wise, it is much higher potency or an equal potency add to that. So earlier in 2003, also people started using sparing protocols, and the sirolimus was started in almost around 523 transplant recipients, and they loaded with sirolimus, and it was done at 3 months after the transplantation. So later, and the people were used sirolimus, cyclosporin, steroid in 215 patients, and others they have withdrawn cyclosporin, and it was sirolimus and steroid in 215 patients. The graft survival is equal and the patient survival is equal. But if you see in those who had only sirolimus steroid, their creatinine is much higher. But you can see the little bit of rejection episodes were higher in those who had sirolimus steroid or calcineurin withdrawal. So we all know that the calcineurins are much potent to prevent rejections. So 2 years, the CNI withdrawal has followed by a maintenance, long-term immunosuppression. The renal function and the blood pressure were very good. If you see the p-value, it was not significant, but then if you see, it was 20% rejection as compared to 14.4. So they had more rejections, but it was not statistically significant. So then the study came as an ascertained trial, which was again done at a later stage at almost a mean time of 5.6 years or 6 months to 10 years post-transplantation. They had a 24 months follow-up, which was a multi-centered study. They had a CNI elimination in 127 patients and the minimization in 144 and a continued CNI without any change. And they followed up for creatinine and also the histological changes. So if you see, there is no significant difference when you change the calcineurin, either you do a minimization or you elimination or with the controls, and the death was also the same, loss of everything was same. So the conversion to everolimus at a later stage has no overall benefit to an adverse events. There are more discontinuations, and the creatinine clearance, if it is less than 50, then they don't do very good. Then there came a juice trial where at 4.5 months, the conversion was done. And those group 1 was cyclosporin with an MPA and steroid. And in the second group, they reduced 50%. And then step 2 was to reduce to 25%. And then they maintained on an everolimus MPA and steroid. So the meantime, it was 4.5 months. And all these patients have received basiliximab and then calcineurin, MP and steroid prior to that. So if you see that GFR was much higher in those who have calcineurin eliminated. You all know that the calcineurin reduces the GFR by vasoconstriction when you don't have, and also the toxicity of calcineurin is taken away, and they have a higher rejection, higher GFR even at 12 months, and also even at 20, it was maintained even at 36 months. So it is significant, almost around 9 to 10 ml GFR, which was higher. Even the incidence of biopsy-proven rejection was 3% more, but it was not statistically significant. Why we have to increase the GFR is, this was a study which was done on a long-term survival of or predicting the graft failure in subsequent years. If the GFR in the first year, at the end of 1 year, if it is more than 40, And these are the patients who do well on a long run. So if the GFR is higher, more than 50, which the transplant trial, a transform trial, which had taken one of the endpoints. So that is the reason the preservation of the GFR is most important. In this, if you see that the surviving grafts, if the GFR upon the follow-up years, if it is less than 40%, they have a higher chance that they will have a subsequently over 10 years, they have a much, almost around 60% survival as compared to 90% survival over 10 years. The other trials were the concept trial and also the Swen's trial, which also showed the GFR is higher in those who have received sirolimus as compared to cyclosporine. So why it is so? Because when you're using an mTOR, you will be able to reduce the calcineurin by almost around 50%, 57% in the other trials which have shown. And so that is the reason why you will have less fibrosis, and the patients have maintained the calcineurin may be maintained at a lower dose as compared to a higher dose which is required without everolimus. And if you see the freedom for rejections, you have to have an adequate level of everolimus. If you have with only this is an MMF, and if you see that it's almost around 18 to 20% rejections, and if you have more than 8 nanograms, you have almost around 3% of rejections. And if you have less than 3, you have much higher rejection as compared to MMF. But you have 3 to 8, it is much rejections are much less as compared to MMF. That is the reason in the earlier slide I have quoted that the potency is slightly better, higher as compared to an MMF. So if you have a good level, then you will be able to reduce it. So if you convert the cons, what are the pros and cons of conversion to everolimus? Either in the late phase, it's due to the introduction of the everolimus, it reduces the anti-tumor activity, and they have a non-melanoma cancers are much less. And also the antiviral property it has, and it reduces the CMV and BKVs, and the anti-proliferative effect it has, and then anti-atherogenic also it has. And but the trials in the lead, it has not shown any reduction in the cardiovascular event as of today. But this has been used in the coated stents and to reduce the anti-proliferation and thrombotic. So the CNI elimination or the minimization may have a favorable graft function. That is disadvantage is basically the adverse events because of the GI disturbance are much more. Antilipidemia or interstitial pneumonia has been documented in around 1 to 2% of the patients. Edema is disturbing, mouth ulcers, proteinuria, and impairing wound healing, and the hematotoxicity are main causes, and which leads to discontinuation of the medication. Due to the CNI elimination or minimization, the risk of de novo DSA still exists, but again, the transplant study has shown that there is no significant increase in the DSA as of today. The another case is he underwent a transplant in 27th of August 2015. Urine output started and the renal function reduced from 5.1 to 2.2, and the second post-operative, third post-operative, he had a fever. As urine grew pseudomonas, and he was treated with antibiotic, and fever subsided, the urine culture was negative. And his renal function came back to normal, and slightly it went up with an infection, and which it improved, but his tacrolimus level was very, very low. So we increased the dose, but still he was not mounting, possibly a rapid metabolizer. So that is the reason in the renal biopsy, which was shown that tubular and mild interstitial edema and a patchy infiltrate, but there was no tubulitis, and he was treated with an antibiotic without any intensification of immunosuppression. He was discharged with on 10th day with 1.37, but because of the persistent, and you all know that if the tacrolimus level is not maintained, they have a higher chance. Earlier, people used to maintain 10 to 15, but we maintain around 8 to 12. There is no rejection. If you have 5 to 10, you have some amount of rejection. Biopsy proven rejection, you see up to 20%. And if it is lower than that, you see much more. So that is the reason this patient was started on an everolimus after around 4 weeks. And he is doing well. So the early conversion studies, we need to know when to start. Either de novo is also okay, early, maybe too early because we are more worried about the wound healing complications. But the transplant study now it has shown that, there are people almost around 13 to 14% of people were from Asian continent, and which also showed that the wound healing complications is less if you choose the patient wisely. And you may have it early also. So the de novo is de novo. Otherwise, early is less than 6 weeks. It will be an early conversion. Intermediate is 6 weeks to 3 months, and if it is more than 3 months, it is a late conversion. So the early conversions are better because if you already have a little bit of proteinuria or an interstitial fibrosis you start, then it will not be reversed. So it is better to start an early or an intermediate start is much better as compared to the late start. The two trials which have done earlier, less than 48 hours and less than 24 hours, they started. And this was a trial of low dose and the moderate dose of everolimus. And the other study which showed an everolimus moderate dose. And the other study which started basically here they saw that with 1.5 and 3, the GFR was maintained throughout, and there was no significant difference with an MMF and this thing. There was no significant difference. So this was the study A2309. It was a study which showed a CNI minimization in renal transplant, which led to the FDA approval of the drug for renal transplantation. This is the 24-month study examining everolimus plus low-dose calcineurin inhibitor and compared with an MPA and a standard dose cyclosporin. It was a phase 3 study. It involved around 833 de novo transplant recipients, and it was one of the largest study during that time, but now we have other studies. So here, within 24 hours after the induction, the transplant, bacilleximab is given on the 4th day, and they have randomized on day 5 onwards to continue. CSA dose adjusted according to the trough levels, and the everolimus level was adjusted to 3 to 8 nanograms, and even higher level was 6 to 12 nanograms, and the MP was standard, and the calcineurin dose was. The primary endpoint was composite endpoint of biopsy proven HQ rejections, graft loss and death, or the loss to follow-up at 12 months and 24 months was the primary endpoint, and the secondary endpoint was the composite graft loss, death, and loss to follow-up and the components of primary. So mainstay was the renal function at 12 months and 24 months to show the efficacy and non-inferiority of everolimus over the standard triple immunosuppression which was there during that time. So the starting dose, if you see the arm in the everolimus arm, the calcineurin dose, the cyclosporin dose, otherwise we keep around 200 to 250, which was reduced to almost 50%, and 100 to 200, and then by 2 months it was 75 to 50, and by 4th month it's around 50 to 100, and on the long run after 6 months they are maintained around 25 to 50, and MPA arm they are maintained around 100 to 250. So significantly the dose was reduced, almost more than 50% reduction was seen, and what it transformed to is it reduced the toxicity. But if you see that if you have an appropriate level, then your rejection probability of rejection is much less. So if you have a level of 200 nanograms, then you will be able to maintain the 4% rejection even at 3.5 everolimus level. But if you want to have at 50 your everolimus level in the 4%, it should be around 5 everolimus level. So if you have an adequate level, your biopsy-proven rejections are much less. If you have a very high dose everolimus, that also dangerous, causes an edema and oral ulcers. So that's the reason why it has to be. So even the GFR maintenance, if you see that it is the negativity or negative change in the GFR, which is much low when you have a lower calcineurin as compared to higher calcineurin level which you require. So if you have an adequate level, then you will be able to reduce the calcineurin dose, and you will be able to have less rejection and maintaining the good graft function. So if you see that the everolimus group had a higher GFR, almost to the tune of around 4 ml to 4 ml to GFR, which was higher. So they had a better maintained throughout the 24 months. They had a higher GFR, but the biopsy which showed an incidence of comparable composite endpoint was not significantly different, 25 and 23 and 32 and 27, which was not statistically significant in the both at 24 months and 24 months and 12 months. So the primary composite endpoints, the biopsy proven rejections were not significantly different, and even the graft loss, death, loss to follow-up, all are the same. And there was some amount, 3% increased loss to follow-up was seen in the everolimus group. But if you see the CMV infections, which were significantly less, as in D plus R plus, what our patients are, which was 13.8% as compared to 4.3%. So almost 3 times less CMV infections in an everolimus group. So even a donor positive, recipient negative, it was all 50% reduction. And you all know that this is the very, very less toxic or less infection in D minus and R minus. There also it is shown significantly reduced CMV infections. Why there is a less CMV infection? Because we saw DD upregulates the T regulatory cells and the significant increase in the CMV, CD8 Tregs and Gerson, and it blocks the inositol 3 pathway, which is crucial for CMV replication. That is the reason your CMV infections are much less. So CMU is an important factor, which because it increases, it's an immunomodulatory virus, increases the pro-inflammatory cytokine, causes inflammation, increased T cell and inflammation, and also it also increases the growth factors, fibrosis, and also it may lead to an increased T cell, and also it may lead to rejection. So tubular atrophy, transplant vasculopathy, interstitial fibrosis, glomerulopathy, all will lead to, and you all know that even the presence of a CMV virus, it may lead to inflammation, fibrosis, and a transplant arteriopathy. So that is the reason why you have to have less CMV infections, even though if there is a disease is also more dangerous, but even infection also should be reduced. So the BKV is, again, when you given more and more immunosuppression, BKV is also an important factor. But in this study, which has shown significantly reduction in the BKV of 0.7 as compared to 4.8. So even the BKV is reduced by the mTOR because the viral multiplication and the protein kinase activated is required for the proliferation. It also reduces. Inhibitors permit the development of CD8 cells, which act against the BKV and clears the BKV much better as compared to the other immunosuppression. Even the neoplasms are also benign and malignant. It was less, but it was not significant. And but the other studies have shown that everolimus reduces the cancer in the majority of patients. So the potential benefits is in low dose calcineurin and everolimus is due to part that minimization, which implicated in the neoplastic progression. Increasing more and more doses of calcineurin increases the chance of getting a cancer, and the direct neoplastic effect of everolimus has also reduces the cancer on the long run. This was the good study by which was published in AGT 2015 by the Tedesco, and in 397 patients, consent was taken in 330. Among them, 89 patients received an ATG induction plus everolimus, and 106 patients received basiliximab plus everolimus and steroid and calcineurin, and 105 patients that received basiliximab plus mycophenolate. And these patients who are on ATG, there was no CMV prophylaxis. If you see that the discontinuation was much less, and 94% of the patients completed 12 months, and here also it is 94%, and 89% completed the study. So there was the dropout rates are all equal in those who have received ATG basiliximab with everolimus or with an MMF arm. So if you see those who have an incidence of CMV, if you see that in those who have treated with an ATG without prophylaxis also, their CMV infection was much less as compared to basiliximab and MPA, which is almost to the tune of around 8%, which is almost here in this around 5%. So the drug concentration, if you see that it is also mean everolimus drug concentration in the thing was which was less, MPA which was not seen, but again, the concentration was maintained around 5 nanograms. So if you have a good nanogram, it is maintained, and you'll be able to use ATG also with everolimus, you'll be able to reduce the CMV infection significantly from 40% to almost to around 6% with everolimus because it has an antiviral property. Again, the cardiovascular diseases are an important factor on all our CKD patients and also transplant. If their GFR is well maintained, you all know that as the GFR reduces, they have more and more cardiovascular events. So if their GFR is better, then their cardiovascular events or the deaths are also much less. If you have a less than 30 ml GFR and you have almost 2.5 times higher risk, 2 times higher risk, And if you have 30 to 45, you have 1.39 times of cardiovascular events. But if you have 45 to 60, you have less 12% less risk. So a better preservation of the GFR, you're going to reduce the cardiovascular events. So the adequate and minimization of the calcineurin allows better blood pressure control, a reduction in the number of antihypertensive agents, and also the beneficial effects of everolimus on the atherosclerotic progression, reduction in the antifibrotic agents, and it leads in even the heart transplants and even the allograft. The vasculopathy is less, and it will lead to less progression. This was one of the trial to show that the less fibrogenicity and what dose we need to maintain. And the everolimus was maintained at 3 to 8 nanograms. And in a higher level, it was 4 to 7, and lower, it was 2 to 5. The MMF, other harm. If you see in the low dose, the tubulitis was not significantly less, or in the higher dose, it was much less. If you see the inflammation in the higher dose, 3 to 8, they had only 0.3 as compared to 0.6 in lower, and otherwise in the high dose, it was significantly less. In attack treated patients, it was significantly 0.4. Inflammation is also significantly less, and the tubular atrophy was significantly less as compared to the low and high TAC. It was only 0.4 as compared to 0.7. So the cumulatively, it was much less. So you all know the interstitial inflammation or atrophy, it determines the long-term outcome. So if you have an adequate level with a low dose of tacrolimus, you may be able to do a long-term. So this was the transplant study, you all know. And here, 1,022 patients after transplant within 24 hours of surgery, and 1,015 patients were given a tacrolimus arm or a cyclosporin arm, and 1,022 patients were received an everolimus, and with the minimization of either cyclosporin or a tacrolimus. So they were reduced from 2 months to 6 months. The cyclosporin is reduced to 50 to 100, and TAC was reduced 2 to 5, and 2 to 4 of tacrolimus, and 25 to 50 was maintained after 6 months to 1 year. It is very, very low dose as compared to 5 to 8, which maintained around the 7, maintained after 6 months to 1 year. And even at 2 months to 6 months, it was maintained around 6 to 10. So the primary endpoint of this study was the biopsy proven acute rejection typically, and the acute rejection at 1 year, and the GFR estimate was done, and it was 1 year. And if the GFR is less than 50 ml, and it is considered as represents the moderate renal dysfunction, and it may represent the long-term survival. That is the reason the primary endpoint was taken in this. So the primary endpoint was the composite endpoint of is basically to see the composite endpoints of biopsy proven rejections and the GFR less than 50 ml, and the other failures is because of the graft loss, death, and other things which were taken as the secondary endpoint. You see, among these patients, the almost around 48% were male, and here in the calcineurin arm, the MPA arm, around 50%. The Asians contributed around 11.7% in an everolimus arm as compared to 13%. So all it was matched. And if you see that the primary or within range was only around 60% of the patients were within range. Otherwise, they are out of range. So either they have an above as compared to the protocol. So everybody, even though the graph shows in the upper limit of the normal, they were still in the higher, not in range. So those, if you see that all the group and also those who have compliant with the protocol, then you had less adverse events. So the CSA level was also in the same, almost around 44% of the patients were in the appropriate as compared to 45, they were in higher range. So the full analysis said the calcineurin level was higher in almost 40% of the patients. So there was no significant difference at different endpoints, either 12 months or 14 months. If you see the compliant set, the GFR, which is less than 50, was much lower in 32 patients as compared to 38. So it was even at 12 months, only 33% to 36%. So had a better GFR if they have a compliant set. So even the biopsy proven rejections, not significantly different, but if they have a compliant set, it was significantly lower at 12 months, and even the 12 months and 24 months, it was same, means that they didn't have rejection in the second year. So the GFR less also, it was 31% and 31.7% in the compliant set, otherwise 44% and 41% in the MPA group. So the others all, if you see that secondary efficacy endpoints, if you see there was no significant difference in the composite endpoints, biopsy proven graft loss or death, even at 12 months or 24 months, it was not significantly different. And the overall DSA, if you see in a class 1 DSA or class 2 DSA at 24 months or even 12 months, there was no significantly difference. That means even if you reduce the calcineurin and you have an adequate dose of an everolimus, you don't have a significant increase in an antibody. So the GFR was maintained equally, so it was almost a similar curve, and even at 12 months or 24 months, it was same. And in the Asian patients, if you see that the GFR is slightly almost around 5 ml to 10 ml, it was higher, 59 as compared to 68. So Asian people, they had fared better. Why, I don't know really, but it is better for us that if you use it, it may have better. So the infections complications at 12 months or 24 months, if you see, the BKB or all viral infections were higher. Otherwise, there was bacterial infections were also there, significantly higher, almost 60% of the patients they had. So the viral infections were less in those who, significantly less in those who had treated with everolimus group. The same thing was there at 24 months also. They had significant less viral infections. So BKB was 1.2% as 2 point, and the CMV infections are also significantly less. So the complications, the most common complications, in edema in 34% of the patients, hypokalemia was important in 14%, and the proteinuria in 14% of patients, leukopenia and BKV infection. So all these were the complications, but again, the predominantly problem was edema, proteinuria, and also the oral ulcer, which was a more common problems. If you see the proteinuria in the two groups, in the everolimus arm, 300 to it was less than 500 ml was predominant, and if you have more than 500 to 1000 was not significantly, only 9.4%, and there was also significant patients who had more than 1 gram of proteinuria. So mild proteinuria is expected, which you can be able to treat with mild reducing the dose or adding an ARB. So this was the Athena trial, which was the prospective randomized trial, and which they used 208 patients with everolimus TAC and 199 patients with everolimus and calcineurin, and 205 patients with MPA and TAC. They followed these patients, and at 12 months they saw everolimus either with TAC or shows a comparable efficacy. So efficacy was significantly good. Everolimus treated patients with less CMV and BKV, you can see that. So they have a significant less CMV and BKV, and no difference in the proteinuria in between the two groups. So everolimus with TAC and cyclosporin have a demonstrate the comparable efficacy in those who have a proteinuria. It's comparable. So patients with the SMA have a significantly less frequent CMV and BKV infections. This is one of the meta-analysis which was published in CJASN and in 2017. And this clearly shows that meta-analysis demonstrates significant reduction in the CMV infections in mTOR group. However, no definitive conclusion is possible regarding the BK polyoma virus infection. So CMV was significantly less. This was the Julius Pascal. They have published a guideline of how to use everolimus, what dose to use it. If it is cyclosporin based, and if your blood is drawn, then you have to start with 0.75 milligram BID. But if it's the TAC, because the cyclosporin, it increases the level of everolimus, and that is the reason you need to have a lower dose as compared to tacrolimus. So if finance is a problem, again, all these drugs are costly and the everolimus is costlier. If you have cost is a problem, you can shift the patient from TAC to cyclosporin. Your reduction in the dose is almost around 40 to 50%. So TAC can be used along with TAC 1.5 milligram BID, and then we need to measure the level at 4-day, 7-day, and after that 51 monthly. And so you'll be able to target the dose, target the level of 3 to 8. So with cyclosporin month, 100 to 150, and that tacrolimus should be around 4 to 7. And at 6 months, it should be 25 to 50 and 3 to 5. These are the recommendations, and the everolimus level should be there at 3 to 8. So the question is, every patient we need to start, or every which patient to start is the question, because in the transplant study they have a non-inferiority, but again not superiority. So every patient, if they are doing good and the cost is less, I think it is not. It is very difficult to start everyone with MMF, everolimus. So if they have a calcineurin toxicity without any rejections, I think these are the people. If there is any mTOR intolerance, or if the person is not getting a good level of calcineurin and the tacrolimus, I think these are the patients possibly. And the past history of malignancy or a present malignancy, recurrent viral infections, and older donors, because they have a more high in rejections, but again, they have a more toxicity of cyclosporin, which they can have. And and if the person develops a TMA with calcineurin, and this may be an alternative. Even older patients, even after that, not only the early conversion, even the late patients, which have shown that if you change over, they also have a beneficial events. So the everolimus level at the biopsy, which was done without any, with everolimus, they show a very good normal glomeruli, and also the tubular dilatation, no atrophy, and the normal artery, as compared to the controls, which usually show that glomerulosclerosis, tubular atrophy, and those things. So in a study where they have functional changes in the Nanki Valley, they have done a biopsy at the change, and at 12 months after that, it's shown that the percentage of tubular atrophy significantly reduced even after that continuously, and the interstitial fibrosis also reduced. And by the different formula, the slope of the curve was significantly less. It was increased, in fact. So even later on, you can be able to do that. Multiple studies have shown that that will be beneficial. And the anti-tumor activity of everolimus is one of the things which will be helpful. So possibly the mTOR will have, it will block, and it will reduce the proliferation, endothelial and angiogenesis it reduces, acting on the lymphocytes and tumor cells, it reduces the tumor growth. By the JAK pathway and reducing the IL-10, it reduces the growth, and also the E-cadherin, the angiogenesis, or the metastasis also it reduces. So the different Kaposi sarcoma, it's one of the good, they have shown that resolution, rapid resolution of the lesion has been documented. Skin cancers and renal cell carcinomas, and even the other solid tumors, the registry have shown a significant better. Every drug has a side effect. The pneumonitis is one of them, but again, a rare, and you will be able to reduce the dose if you only have a cough, reduce to 4 nanograms. If it is moderate to severe, you need to discontinue. Possibly there is some component of immunological, and you may have to use a steroid in those patients, which will recover. Delayed wound healing is there, but again, it's only in some patients who are obese and diabetic. If the BMI is more than 35, they are highly prone. So we have to be cautious in choosing those patients. Though you can reduce the dose and surgical intervention can be done, but it is very, very disturbing, then we need to stop it. Lymphocyl, non-obstructing, you can maintain. It's an obstructive, reduce the dose and see and drain it. But if it is recurrent, we may have to discontinue. Proteinuria, if it is less than a gram, then maintain by add on ACE inhibitor, ARB, or an aldosterone blockade. And if it is more than that, more than 3 grams, do a biopsy to see is there any associated glomerular diseases. Peripheral edema, you can reduce it, and then if it is persistent, we may have to remove it. So the disturbing is a block stopping. Yes. So if there is any BMI is more than 35, then we need to, if there is any focal segmental glomerulosclerosis, we need to stop. And if there is any vascular abnormality, we need to stop. To conclude, short-term transplant outcomes have improved. Marginal improvement in the long-term outcome has marginally improved. The everolimus with low-dose CNI is non-inferior, and the graft loss and the biopsy-proven rejects are equal. Early conversions is better. Viral infections are better, and the malignancy in post-transplant is better with everolimus. And there is no significant DSA even with lower. So everolimus low dose with CNI can improve the graft survival. Thank you very much.
Thank you, Mahapati. This is another interesting and practical aspects in management of patients with slowly creeping creatinine. Now, I want to ask you that in what percentage of your cases you have had to withdraw everolimus because it was not tolerated, amongst patients who were put on everolimus, in what percentage you had to withdraw?
So we had to withdraw in 10%. If you take the GFR is okay and the proteinuria less than 10%, then the 800 milligrams, we take a cutoff of 500 milligrams because there will be some increase. But still, we have around 8% of the patients, 8 to 10%, we had to stop because they start getting an edema. Not only now, even after an year, we got it. And so in those patients, we had to stop. It's only around 8% of the patients.
What about oral ulcers and pneumonitis?
Pneumonitis in sirolimus, we had 2 patients. We had pneumonitis. One we had to stop it, and then the ball showed lymphocytic infiltrates. We given steroids. He was continuously having a spiking fever and hypoxia, and he improved. And we didn't re-challenge him because we are afraid. And 2 patients we had. Otherwise, with the everolimus, we didn't have it. But oral ulcers, yes, if you reduce the dose and use the triamcinolone oral ointment, they improve. But we did not have to stop the everolimus for an oral ulcer.
Okay. There is a question from Dr. Prashant Rajput on the chat box. Any study done where spironolactone with everolimus has been used to reduce fibrosis in patients with creeping creatinine?
I don't aware, but again, they say that is a side effect when you have proteinuria, you use either aldactone blockade or those things, but there is no study to show combination of both everolimus. Again, both are antibiotics. It's a good thing, but there is no study which I am aware of that both the combination reduces.
There is a question about when you have chronic allograft nephropathy, what is your approach on introducing sirolimus? I'm not sure whether you are using sirolimus or you use only everolimus.
We were using sirolimus earlier. Now again, if it's a cost consideration, we still use it because sirolimus is much cheaper as compared to everolimus. We use it, but again, the edema was much higher percentage as compared to everolimus. So everolimus or sirolimus, both are mTOR, but again, the duration of action, and we have to come down on the dose, which is much easier with everolimus. That is the reason we are preferring everolimus.
Okay. I'm sure there must be others here who must be wanting to make some comments. Well, if there are no more questions or comments, thank you, Umapati, for a very good coverage of everolimus for early conversion after transplant. And we now request Dr. Vivek.
Thank you, sir.
Thank you, Umapati. Vivek Kute to take over, and he will be talking to us about induction immunosuppression. So over to you, Dr. Vivek.
Thank you, Dr. Bharat Shah, for giving me this opportunity to talk. Screen is visible?
No, not yet. Yes, now it is visible.
At the onset, I would like to thank Professor Bharat Shah, Dr. Shruti, and Narmada Kidney Foundation for giving me this opportunity to talk on long-term outcome with different induction agents. India has performed more than 12,600 organ transplantation over the last 6 years from 2013 onwards. 85% are living donor and 15% are deceased donor. So really the long-term outcome do matter for our scenario because especially we have the living donor organ transplant program. The topic outline unmet need in kidney transplantation, need of induction therapy, what are the guidelines, and what is a long-term outcome data of safety and efficacy of depleting versus non-depleting induction therapy. What should be the ideal outcome after kidney transplantation? Improving long-term outcome without compromising short-term gain. Low incidence of malignancy, low incidence of cardiovascular disease, no donor-specific antibody or immune injury, low incidence of viral infections, and low incidence of acute rejection. That is the ideal goal of any organ transplantation. Factors influencing the long-term survival in organ transplantation. Long-term graft survival is based on multiple factors. Long-term outcomes are based on donor, recipient, immunosuppression, and post-transplant graft function. Current immunosuppression regimens are highly efficient in preventing acute rejection, but the burden of specific and non-specific side effects has significant negative long-term consequences after organ transplantation. Death with functioning graft is a major cause of graft loss after kidney transplantation in patients more than 40 years. This is paper published in Transplant International. What are the common causes of kidney allograft losses? 50% death with functioning graft. So what are the causes of death with functioning graft? Cardiovascular disease, 40%, 25% infection, 10% malignancy, 25% other causes. So this is the most common cause. In Indian scenario, the tropical infections like tuberculosis, malaria, they are important to contribute infections in death with functioning graft. 50% are chronic allograft failure. Chronic allograft failure, it is divided in two parts. 20 to 40% drug toxicity, new disease, recurrent disease, and acute rejection. With the available induction and maintenance therapy, over the last 50 years, we have controlled the acute immune injury. But on the ground reality, there is no much significant progress made in the research to overcome the chronic immune injury. The chronic allograft failure is again divided in alloantigen dependent, acute rejection, histocompatibility mismatch, prior sensitization, suboptimal immunosuppression, medical non-compliance, very common in our scenario, and ongoing humoral injury. And immune injury independent causes like old age, CNA toxicity, hyperlipidemia, hypertension, infections, proteinuria, they contribute to non-immune injury causes of chronic allograft failure. Need of induction. Need of induction is risk of acute rejection is maximum in the initial 3 months after transplantation. Need for initial strong immunosuppression to deplete or modulate T cell response at the time of antigen presentation. Many agents can be used for induction, but nowadays antibodies became synonymous with induction therapy. Multiple trials shows that induction therapy either delay or prevent development of acute rejection. As per 2008 data, 82% patient received induction therapy before organ transplantation. The induction therapy is of two types, monoclonal and polyclonal. Monoclonal are the homogeneous murine hybridoma technique, genetic engineered for chimeric or humanized modification. Their response is predictable, small dose is required, and more susceptible for immune elimination. Polyclonal induction therapy, heterogeneous, harvesting serum from animal inoculated with human thymocyte or lymphocyte, variable reaction, large dose is required compared to the monoclonal and less susceptible for immune elimination. Depleting and non-depleting agents. Depleting agents, they are used for induction therapy, for BAMF 2 and 3 rejections, refractory rejection, and rejection in high-risk setting. Non-depleting agents, they are used for induction therapy, rescue therapy. They are mainly used for low immunologic risk transplantation. What are the problems with the depleting antibody? Cytokine release syndrome, less common with today's era, more semi-fungal pneumonia, PTLD and malignancy, cytopenia, especially with the depleting antibody, homeostatic proliferation of CD8 cells, reduction in Treg, CD4 memory cells are resistant, increased propensity to autoimmunity. Which are the ideal candidate for induction therapy? It is a HLA mismatch, young recipient, old donor age, Indo-African ethnicity, PRA more than 20%, cold ischemia time more than 24%, delayed onset of graft function, presence of DSA and blood group incompatibility. Now the risk stratification is done in two cases, like low risk group and high risk group. So which are the low risk patient? Zero HLA mismatch, living donor, Caucasian ethnicity, low PRA, absence of DSA, blood group compatibility, immediate graft function, short cold ischemia time, and first transplant. So majority of the transplant in our scenario we see as a low risk patient because they are the first transplant mainly from the parents as a donor. So low risk transplant recipient population is high as compared to high risk patient, which are defined as a high risk patient, increased number of HLA mismatch like deceased donor and spousal transplant. Young recipient and old donor age, African American ethnicity, high PRA, DSA, blood group incompatibility, delayed graft function, long cold ischemia time, and retransplant. So it formed less than 40, less than around 30%. So what are the different guidelines to discuss about the induction therapy? KDIGO guideline, it recommends starting a combination of immunosuppressive medication before or after kidney transplantation. It is a 1A recommendation. KDIGO recommend including induction therapy with a biological agent as a part of initial immunosuppressive regimen in kidney transplant recipient. We recommend that non-depleting agents like IL-2 blocker as a first line therapy. We suggest using lymphocyte depleting agents rather than IL-2 receptor blocker for kidney transplant recipient at high immunologic risk. Then there is a KARI guideline. It also adapted the KDIGO guideline. The KARI-KDIGO combination suggests that induction therapy with biological agent as a part of initial immunosuppression in kidney transplant recipient. They recommend IL-2 blocker as a first-line induction therapy, suggest induction with loading dose of mycophenolate be considered. In kidney transplant at high risk of acute rejection, consider T-cell depleting agents in place of non-depleting agents. What is the long-term data on efficacy and safety of non-depleting and depleting induction therapy? Here we can see the graft survival, duration of follow-up in months on the x-axis and survival on the y-axis. 1, 2, 5 and 10-year patient survival. Death censored and death non-censored graft survival was superior in patients with induction therapy with non-depleting agents like basiliximab compared to patient without induction therapy on long-term follow-up of 10 years. Then what is the difference in variables in the ATG and basiliximab group? We can see there is no statistically significant difference in patient survival, graft survival, death censored graft survival in thymoglobulin group versus basiliximab. The other variables like delayed graft function, acute rejection, there is also no significant difference. Graft survival at 6 years was 89% and 83% with thymoglobulin and basiliximab respectively. Incidence of biopsy proven rejection episode 33 versus 26 and delayed graft function 30 versus 33 were similar in the two groups. Kidney function was not significantly different at 1 and 6 years. Then CMV and hematological complications in the two groups. We can see there is a statistically significant difference in anemia, leukopenia, and thrombocytopenia. With thymoglobulin, the higher incidence of complication as compared to the basiliximab, lower incidence of this hematological complication. Then CMV infection higher with depleting agents as compared to the non-depleting agent. Then graft survival in low dose ATG versus basiliximab was comparable. We can see the Kaplan-Meier curve. Then what is the difference of CMV and BK despite using low dose of thymoglobulin? The CMV and BKV incidence is higher with low dose thymoglobulin as compared to the basiliximab, and the value is statistically significant. The other parameters like bacterial, fungal, and tuberculosis, they are higher with the depleting agents, but value is not statistically significant. To conclude, multiple trials shown that induction therapy either delays or prevent development of acute rejection. KDIGO recommends that IL-2 blocker is a first-line induction therapy. Acute rejection was significantly less in patients with induction compared to patients without induction. As per available data, more infection rates are seen with thymoglobulin as compared to basiliximab. Death with functioning graft is a leading cause of graft loss in patients more than 40 years. Thank you for your attention, and with this I will conclude my talk.
Thank you, Vivek. What we would like to learn from your huge experience of so many transplants is what has been your experience with the induction agents that you use in your clinical practice.
Yes, sir. We have the experience which
Can
is.
you stop sharing the slide first?
Yes, yes.
Right. So Vivek, we are in a different scenario in our country. Our infectious complications are different from what they see in the Western country, and therefore I would want to know what has been your induction agent, what has been the uh, outcome with different induction agents that you have used in your experience, and what has been the complication with those induction agents.
Yes, sir. As we have seen in this is data from developed world where infection are common with the depleting agents. In Indian scenario, the scenario of infectious complication are much higher as compared to the Western data because tuberculosis, malaria, tropical infections, they are very common in Indian scenario where we use induction or we don't use induction. So definitely the infectious complications are higher with the depleting agents, that is thymoglobulin, and infectious complications are less with the non-depleting agents, that is basiliximab. And we have the similar strategy like in low risk transplant we use non-depleting agents basiliximab, and in high risk transplant we use depleting agents, for example cadaver patients, uh, poor HLA and spousal donor. So our scenario is similar, but we must say whatever Indian scenario, the infections are common, very common, even when we don't use the induction therapy, especially because this is our experience from the public sector transplant program, where nutrition and of the patients is very poor, and they depends on the government scheme, so they have very late referral to our hospital when they come from distant area. So these are additional factors which contribute to more infection in our experience.
So, as you said, Vivek, when we have someone who is nutritionally very poor, elderly, and frail, we also do not use any induction agent. And we find that the rejection is not as much a risk even without using any induction agent with the current triple immunosuppression. What I would want to know is there a difference in infectious complications that you see when you use basiliximab for low risk people and when you use thymoglobulin in high risk immunological risk recipients? And when you use thymoglobulin, what is the average dose that you use?
Definitely, the infectious complications are less with the basiliximab as compared to the depleting agents. Although we use a low dose of thymoglobulin, like for the parents donor, we use 1.5 mg per kg, and for the spousal donor, we use around 2 to 2.5 maximum mg per kg. So this is again the tropical scenario, public sector hospital, other factors which contribute to the higher infection in the depleting agents.
What must be your incidence of post-transplant lymphoproliferative disorders?
PTLD is less because they are mainly seen in the very long-term follow-up, maybe like 15 year, 20 year. So I have not seen more than 10 patients in the last 10 years when we have performed 6,000 kidney transplants.
Okay. I'm sure there must be some questions from others who are participating in this webinar. Umapati, do you want to make some comments? You'll have to unmute yourself, Umapati.
Our people have more infections because socio-economically also they have, and they are staying far off. Once they have an infection, coming to the hospital get delayed, and that increases more complications. So unless there is a compelling indication, we don't use in everyone an ATG. And if you're using also in spousal and other things, we are restricting to 3 milligram and 2.5 to 3 milligram and not more than that. Still, we see a BKV and CMV is more as compared to those who have not received the induction or a basileximab. So we have to monitor these patients, and we have to tell them that if you have any problem directly, immediately come to the hospital so that it can be taken care of.
Okay. Okay. Dr. Samir, you had some questions earlier. Samir Vahalkar.
No, sir. No, sir. Thank you.
Okay. Any other comments?
Yes. No, regarding our practice of using induction, I think it has to be very well balanced between the risk of rejection versus the risk of infection. The three most important factors which we have found which increases the overall morbidity and mortality is the age of the patient using induction in a very elderly age group, especially more than 65 years with a depleting blood. Definitely the risk is high. Second is use of induction in diabetics. Even high risk diabetic patients, we have to be very careful with the use of induction agents. And the third is the net state of immunosuppression. So the overall important decision-making process, I think individualization, that has been what we have started practicing now. Based on the risk of rejection and and weighing it with the risk of infection. I think your comments.
Is Jitendra still there? Jitendra is still there?
Yes, I am here.
Jitendra, any comments from your end?
Overall, our experience is that the time and again, when we are reviewing the infectious data, it has to be balanced with rejection. And time and again, we are coming to the same conclusion that steroids are more dangerous than anything else. So we just have to curtail down the dose of steroids as soon as possible. And ATG and thymoglobulins are out of the way is as induction therapy. They have to be only used in very resistant humoral rejection where you can't use plasmapheresis.
You mean even in humoral rejection?
Yeah.
Thymoglobulin would be a good anti-rejection agent to use?
That I said that's the last line of.
Your voice is
That's
breaking.
the last line of therapy.
Your voice is breaking.
Sorry, can you hear me?
Yeah, now I can hear you.
So in our centers, we do not use ATG unless it's a very resistant rejection, or we have failed the initial line of therapy like plasma exchange and monoclonal antibody.
Okay. So what is your induction agent? What is the induction agent that you use?
The usual standard what you are using, basiliximab,
steroids and CNI, tacrolimus, and depends upon MMF basically.
So
we got two
don't
lines of
use-
therapy. We
you
have
don't
got
use-
classification as
You don't use thymoglobulin as an induction agent?
not at all.
Oh, okay.
So the way we design is our immunosuppression is designed in or classified into two classes. The first one is a low risk and then high risk.
Right.
And the high risk is defined as those who have had previous transplant or triple mismatch.
Yeah.
And the rest would be low risk. So in the low risk one, we use prednisolone, tacrolimus, and azathioprine. In the high risk, we use MMF instead of azathioprine, and the basiliximab remains the same. Mind you, this is what we use for all the cadaver and live unrelated or related transplant. It doesn't matter. But if it is a live related, we use them as a low risk transplant.
So in low risk cases, you don't even use mycophenolate. You use only azathioprine.
Yeah.
That's nice. That's nice to learn.
Because what we are worried is in the initial days of transplant, when you got steroids on board, the risk of rejection is low. And even if you reject, it's a rejection. It can, and just giving the right dose of tacrolimus can reduce the risk of infection and rejection at the same time.
And what is the lowest dose of steroid that you come down to?
Yeah, so we start with 500 milligrams of methylpred, and we just go with a standard dose of 20 milligrams, irrespective of the weight.
When? From 20 milligram from which day? You go to 20 milligram on day 1 after transplant? Hello?
Sorry, couldn't hear you.
You go down to 20 milligram after how many days of transplant?
First day.
From day 1 itself?
Yes.
Oh,
okay.
And my experience with the Indian and the British people, as well as the Indian people over here, I have experienced that even 20 milligrams is quite a high dose for them.
Okay.
And if you remember when I did my analysis of our data,
yeah,
we found that we had a higher incidence of having AVN.
Yeah.
So that's the major risk we carry. We use high dose of steroids.
Right.
So I would suggest our Indian population, the lean body mass is low, and our BMI is also very low. So we should use a very low dose of steroids and come down very rapidly, because it reduces the risk of infection and steroid-related complications. So my suggestion is to go down to 20 milligrams. It won't harm the patient, nor it will increase the risk of rejection.
And what is the lowest dose you go down to?
5 milligrams.
By what time?
It would be around 6 weeks.
By 6 weeks. Okay.
Yeah. So first 4 weeks
By
it
8
remains
weeks.
20.
So
And
we,
then
we also go down to 5 milligram by 4 weeks.
8 weeks, yeah.
But we taper. We don't go from 500 to 20. We go down slowly.
Yeah, well, the problem what we are exposing is in the immediate post-transplant, you already got heavy immunosuppression because of high dose of TAC and basiliximab. So the cumulative effect of the steroid is quite heavy in the first 4 weeks. So what we want to reduce is the cumulative effect of the steroids.
Okay.
So you've got a patient who is already immunosuppressed from the uremia.
Yeah.
And if you over immunosuppress, then there is a high risk of infection.
Right. Well, thank you, Jitendra. Any other questions? There is one question, Vivek. Do you reduce MMF to 1 gram per day when you use thymoglobulin?
Yes, we reduce to 1 BD with the
Okay. Okay. Yes.
So Bharat, I think we also had this risk stratification, wasn't it? When we used
correct
immunosuppression.
We always use risk stratification, and we not only use risk stratification, but we also look at risk of infection. So elderly and diabetic, we consider them to be at high risk of infection. So we try to minimize the immunosuppression and induction.
Dr. Jitendra, what dose of MMF do you people use it?
We got two ranges. It's weight dependent. We start with, I think we are using 1 gram BD for those who are weight more than 70 kilos, less than 70, and weight more than 70, we give 1.5 grams twice a day. But then it depends if they have immune response in terms of having diarrhea and all, we curtail down quite quickly. Another thing to remember now is with your corona around,
lymphopenia.
We would not allow you, we would probably avoid using MMF. So I would suggest don't use MMF.
What about Azoran?
You can continue azathioprine. It doesn't matter, but low dose again. So we use, I think, 2 milligrams per kg, isn't it? I think we can use it 1.5 or 1 milligram. That's also fine.
Yeah.
But what is important is about getting rid of the azathioprine and MMF in and around the corona time, because there is a high risk of serious infection in these patients. And I would suggest that what we have looked through our data on use of ACE inhibitor and ARB, we found ARB to be protective against corona compared to ACE inhibitor.
Now we hardly use ACE inhibitors because of the cough complication. Most people are on ARBs only.
Now that's a good thing. I think that will give some protection rather than nothing.
Yeah. Okay. Any more questions or comments? If not, we bring this webinar to an end. I'm glad that we have had good discussion on each topic and a very good coverage of the subject by each speaker. I would like to thank each and every speaker for participating in this meeting and giving a good coverage of the subject along with their own experience. And that is what is most important. We all have to learn from our own experience. With this, we bring this webinar to an end. Thank you.
Thank you very much, sir.
Thanks
for arranging it.
Thank you.
Dr. Jitendra, nice talking to you.
Yes, Umapati, I've seen you after a long time.
Yeah. Hope
Are you
every...
still
Hello.
Where are you at the moment?
Nadiad.
Nadiad, okay. How is Dr. Rajapurkar? Is he there?
He's fine. Yeah, he's fine.
Tell my regards to him.
Definitely.
Nice speaking to you.
Yeah. Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye-bye, sir.
Bye. Thanks, Dr. Barista.
Yeah. Bye, Jiten.
Bye.